Good afternoon, everyone. I'm Dr. Allison Iwerty, Commissioner at the Chicago Department of Public Health. Thank you for joining us. Today is, let's check, Tuesday, September 29. And as always, we are here to take your COVID questions and have some conversation. So as you can see, we have a special guest with us today. This is Antonio King, and he has been at the Chicago Department of Public Health, what, 15 years?
15 years. It'll be 16 in October.
Oh, that's amazing. He's a public health administrator, and he serves as our LGBTQ health outreach liaison, does a lot of work in the HIV section, and then in the time of COVID.
Yes, I've been transitioning. Well, with HIV, I've been in that particular position for 15 years, and working as an STI supervisor and a DIS, a disease investigative specialist. And right now, I have been transitioned over into COVID, working not just with the LGBTQ community, but Chicagoland as a whole, as we implement the new contact tracing programming, SCDPH.
Yes. So lots of things to talk about that I know people will have questions about. Tell people a little bit actually about some of this sort of DIS work and the STI, some of what you were doing prior to COVID that people may not know, and how that fits into the current contact tracing conversation.
Well, prior to COVID, immediately prior, as the LGBTQ Health and Outreach Liaison, I was working with our LGBTQ community within Chicago and every entity within the health department to ensure the health and welfare of the Chicagoland residents that are LGBTQ or those family members. So prior to that, I was with HIV and the STI division as a partner services supervisor in DIS, meaning that whenever there was a positive sexually transmitted infection, we followed up on that. We made sure that the person was treated and that their contacts with their partners were also treated and followed up on as well with doctors and coming into our clinics and stuff. So that kind of gave me a special expertise in how to talk with contact tracing patients who have been COVID impacted, those who have been exposed, and to elicit that information from them as to where they've been and who they might have exposed as well, and to follow up with them that they've got the adequate treatment, and that they're isolating themselves and quarantining and doing those things with their family that they can do to ensure their safety as well.
Yeah, exactly. And this is, we've talked a little bit on here about that, the work of case investigation and contact tracing is something that the Chicago Department of Public Health has done for decades and decades. Yeah. And we're just using some of this, and people who have a lot of experience in this space, we've been able to take some of that expertise and try to use it. But now with the community-based contact tracing, there's even a different component there. So, all right, so go ahead. You can start putting questions in for either Antonio or myself. Hashtag Ask Dr. Iwerty. You can use Facebook or Twitter. You can also just put questions in the box below. I'm going to go ahead and do a quick data update, and we're already getting a number of questions in, I was seeing, from people with questions about yesterday's announcement. So here, for example, is at Illinois Spark on Twitter, who's asking why 4.3%, meaning percent positivity, and not last week's 4.5%. Would 4.4% positivity merit the same lifting of restrictions? I guess the question is, why now?
Why now?
Good question. We got a number of variations on that. So we'll hit the dashboard really quickly. And then I think what we'll actually do, maybe, because I don't know that everybody saw the press conference yesterday, is I think I'll just take a couple minutes and talk through some of the data about why now, and some of the restrictions, because I know there will probably be questions. But also, start putting in your questions for Antonio, because we want to hit both of these.
We're on Twitter too?
We're on Twitter too. Yeah, first question here was from someone on Twitter. So, and there's some other questions here, a number of things about the
Yes,
things.
please send your questions in.
Yes. All right. So here is our dashboard. As always, chi.gov/COVID-. And as we can see, today we are at around 300 cases per day. And of course, our ideal state would be to be below 200 cases per day. We really don't want to get to 400 cases per day. And so part of the question is, how are we able to relax restrictions given that we're at that 300? That's what I want to actually help you understand, how the same metrics that we laid out as we moved into phase 4 at the end of June are the same metrics that finally we hit here that let us move forward. Our test positivity, you can see, is at 4.3%. Again, we want that below 5%. And our testing is looking very good at more than 8,200 a day. If we go over to the demographic data here, we can see that deaths are averaging 2 per day. They've been low. Our person positivity is at 7.7%. So, yep. So, you know, that was over 8%. It's coming down, but we'd like to see that come even farther. So, so we're going to go ahead here and pull up, I got it here, some of the data from the press conference that we showed. Just got to turn this into a, there we go. Thank you. Okay, so so what happened yesterday was that we made some more changes in phase 4. And those of you who may not have been following all the ins and outs of this, we had put some stricter requirements in place than have been in place across much of Illinois back in early July. And this was an announcement yesterday that we were relaxing some of those additional restrictions that we put in place. We still have stricter requirements in place than most of the rest of Illinois. But very specifically yesterday, so first, we expanded indoor capacity from 25% to 40%. But we did maintain that maximum of 50 individuals per space. So that would be in restaurants and gatherings, indoor spaces, et cetera. We kept things like the requirement for tables at restaurants to be at 6 individuals, and we didn't change anything on outdoor gatherings. They're at a 50% capacity with a max of 100 individuals. We also announced that bars could reopen indoor seating, but only at 25% capacity. We put the sale of liquor for restaurants and bars back to the longer hours of operations where they'd been. Yep, 1 a.m. For liquor sales and 1:30 at the max for operation. We also expanded the size of classes, after school programming, childcare group sizes went from 10 to 15 individuals, and that's because we've, you know, broadly, as long as there's been good mask adherence, not seen major spread in some of those settings. And we said that personal services that required the removal of face coverings could reopen. So people who want to get their beard trimmed or, you know, want to get the facial, those had not been allowed. Yeah, I know. That's been one of the I was
mad about that.
Yeah. But we did, you know, want to emphasize some additional requirements. One is just around the restaurants that, as you know, we've been making a big deal about masks. Like when you sit down and you're having dinner with up to 6 people at your table, presumably those are all people that are in your bubble. They're in your household, or at least you've had those conversations about the risk people are taking, and you know what that risk may be. But for your servers, for the other people in the restaurant, like they did not have the opportunity to have that same exchange. And so really just emphasizing that you got to wear your face covering really while you're seated, you know, and when they're coming in. Basically face covering on all the time,
when you're not
except
eating.
when you're eating or drinking. Can't eat or drink through the mask. And there's some more information about restaurants collecting information for possible contact tracing, and really double down on the fact that bars and breweries and taverns have to have customers seated when eating, drinking, or ordering. So not going up to the bar. This is again about maintaining that social distancing space. And then that the personal services, as much as possible, we want to keep it to under 15 minutes. And so if these are express facials and beard trimming as much, you know, as much as possible. Just again, recognizing that
a quick shave,
but that longer exposure increases the risk, and that the employee really must always wear a face covering, and just doubling down a little bit that all places of business need to be providing hand sanitizer when folks are coming in. But I wanted to highlight here just the data and the reopening metrics. So some of you have been following this very closely, I know, and these are available. We update them every single week. We do an update on our reopening metrics, and if you go to chicago.gov/coronavirus, right up at the top under latest data, you go to reopening metrics, you'll see this. But this table here, there's a lot of information on here, but it really highlights the 8 things that CDPH has been following all along, and set the requirements for where we might be able to move ahead in terms of reopening, where we would be pausing, or where we would need to delay or perhaps pull back. And so just to kind of talk, you know, cases through to give you an example of this. What you can see for cases, hospitalizations, deaths, and emergency departments, if we're seeing any sustained increase that goes more than 14 days, basically one incubation period within the past 28 days, we are not in a place to move forward, and in fact could need to take a step backwards. Right. If we see an increase that's less than 2 weeks, we're kind of in the pause and monitor, where are we going? And then we only get into sort of go, which we consider cautious progress, continued progress, or advanced progress, where we're seeing stable or declining numbers for all of those cases, hospitalizations, board, deaths, right, and emergency department visits. And so, cautious progress is when we see a decrease, but it's been less than one incubation period. Continued progress is when we're somewhere between 14 and 28 days. And then advanced progress is where we see a stable or decreasing numbers for more than 28 days, more than 2 incubation periods. And you'll note that specifically, we actually laid out at the end of June 2 things that keep us in advanced progress. One is stable or decreasing for 28 days, and the other is sustained under 200 cases per day. Because under 200 cases per day, as we've talked about a lot, takes us out of that high-risk state, lets us continue to move ahead. And so the first answer for sort of why now is that we've actually hit the metric for advanced progress. Yes, thank you to everybody for that. That really since the end of August, August 24th, we've been on a slow but steady decline. A little bit of dip around Labor Day testing, and we had to make sure that had worked out. But we had seen, although it's been slow, stable or decreasing numbers, and that's really what we had set. Similarly, under positivity rate, you can see that more than 10% says to us, stop. Can't move ahead, in fact, may need to move backwards. 5 to 10%, which is where we've been for like weeks, is like yellow, we just got to pause, we can't do much, and we have to be under a 5% positivity to even consider moving ahead. And again, there's 2 positivities here. So the test positivity at a minimum needs to be under that 5%. And then we lay out some specifics around hospital system capacity, testing capacity, and response capacity, which have some specific numbers on them. And we've been green on all these for a long time. Yes. So really it was more what's happening with cases. And so if we look at those just quickly, people are used to this graph at this point. And it says current 299 because that's where we were yesterday. We've been right around 300. You can see that in the green line here is the 200 cases per day. The red line is the 400 cases per day. And if we focus in on phase 4, which is all the rest of this does, since we moved into gradually resume at the end of June, here is that zoomed in area. You can see that all the way from June, all the way up to late August, we were just on an incline here with cases. When we're on an incline in cases, deaths, hospitalizations, any of these things, that is not a safe setting to be relaxing anything. But from late August, over all of September, slow but steady decline. You can see we had this big dip related to testing in Labor Day week because we had 3 days in a row with very little testing, and then saw that we had to make sure as that popped back up, it wasn't going to rise up in a way that would make it come down. But basically, we were at stable or decreasing for more than 28 days. And then similarly, here's what our hospitalizations look like during phase 4. And even from a distance, you can see that that's been on the decline. And then we use our epidemiologists use a statistical, something called join point that actually looks statistically about are there differences. So we don't just eyeball it. It's like, is there an increase, is there a decrease? And so since August 27 in this case, again, more than 28 days, we'd had stable or decreasing new hospitalizations. And this is in Chicago residents. So at this point, we've got about 14 new hospitalizations per day in Chicago residents. And all race ethnicity groups are in low incidence in terms of, or out of high incidence in terms of that. So that's very good. And then similarly, if we look at our deaths during phase 4, as we were coming out of phase 4, we still were averaging 14, 15 deaths per day, and 50 was what we were at our peak. But you can see that this really settled, and by July we were down in this sort of 3-4 range, and that's been consistently stable or declining since June. So that has looked really good. And the difference here is, I think, that we've had this major change in who is getting COVID, where, we've talked a lot about how over the summer our 18 to 29-year-olds are driving a lot of cases, followed by our 30 to 39-year-olds, et cetera. But they've been doing a good job of not infecting the 60-plus-year-olds. And thank you to people who are older and are being just really careful with their health and cautious, because I know how hard that is, but we've just in the data seen much, much better rates of infection among older folks, and that's meant that we haven't seen as much of the increase in the hospitalizations or the deaths, which is really good. And then here, similarly, our emergency department visits, these are not necessarily people tested for COVID. They don't count in the numbers, but it's what we call syndromic surveillance. We look at everybody coming into emergency departments, and sort of behind the scenes, in an anonymous way, are people coming in with symptoms that could be COVID,
And
right?
that's syndromic?
It's called syndromic.
Syndromic.
Yep, meaning like fever, these syndromes.
Okay,
So we do this for influenza too. The idea is people are coming in, you don't wait for a test, you don't count individual numbers here, but we know from doing this kind of work for influenza, you can really see in the emergency department visits when influenza starts to take off. And so there's been
I can get.
Yeah, so there's been a COVID-like illness syndrome, it's called, that's been set up and we've been following. And the good news is this was really flat all through phase 4 here. You can see in June into August, and then similarly, really since late August, concurrent with the decrease in the cases we were seeing, we also saw a really nice fall off in emergency department visits. And that helps us know that it's not just a testing thing, which obviously we check for. These are ways that we know there's actually been improvement over the last month, and improvement for that more than 28-day period, which again helps us feel more confident that we're at a place to potentially loosen restrictions.
Come on, Chicago.
Come on, Chicago. That's right.
Yes.
And then here's the positivity. So this purple line shows, again, in phase 4, what our test positivity has looked like. And you can see early on in July, it was going very well. It was under 5%, as low as sort of, looks like here, 3.8%, really looking pretty good. But then we saw in mid-July a big increase here. And it got up over that 5%. And you can see we've just been fighting with it for like months, a couple of months. And only really since September 10 did we consistently have that percent positivity down under 5%, and that was hitting the 14 days there. So it hit continued progress in terms of being stable or decreased 14 to 28 days, down to 4.3%. So finally we'd hit both the combination of those things up top that we follow, as well as the positivity rate.
We need to stay there.
We need to stay there. That's right. That's right. And and to that point, we use those same metrics for if we need to go backwards, right? Like this doesn't work just one way. It's a dimmer switch, and if we see, we pause where we're in pause, if we get into red, that would be where we would put restrictions back in place. But when we hit the metrics we've set out, we act on them. So. And then here's what our hospital capacity has been looking like. This has been very, very good. I just put up here the hospital non-ICU beds on the left. You can see our goal is to be below 1,000 back in for COVID patients. Back in April and May, we were above that. But right now, when we ran this yesterday, averaging 259 patients with COVID or even potential COVID waiting a test across Chicago hospitals. And that's been declining throughout phase 4. Similarly, ICU, goal is below 400. We were above that during our peak, and we're at about 89 right now and flat this whole summer. And ventilators, same thing. Goal is below 300. We've been at about 45. Teeny uptick in the last week around some patients on ventilators. Some of that has been patients being actually transferred into Chicago hospitals who are not from Chicago necessarily, but they're sicker and coming to get...
I didn't realize that was where that number was coming from.
Yeah, because this is hospital capacity. So this is just anybody who is in Chicago hospitals, as opposed to the first number that we report, which is the Chicago hospitalizations. Those are our Chicago residents that are like our cases, our deaths. That's about people who live in Chicago. But also from a capacity standpoint, we track bed availability. It doesn't matter where you're from. If you're in a hospital bed in Chicago, we need to know about you. So yeah, it's a great point. Like that's the difference between those two numbers.
So even with the ventilators?
Yeah.
Okay.
Yep, even with the ventilators. Ventilators, ICU beds, hospital beds. If you're in a Chicago hospital, you get counted in these hospital capacity numbers. And then our testing capacity, which again, you can see we'd set that goal of 4,500 or more per day. That represents our ability to test 5% of Chicago residents every month. It's sort of a standard benchmark. And we've been above that consistently since middle of June and on the increase. Particularly, this is where the percent positivity comes into play a little bit. You want to make sure you're doing enough testing also to keep your percent positivity under 5%. And so you can see we're averaging now about 8,200 tests per day. We did have that dip over Labor Day again, so we were just watching to make sure that that was coming back up. But testing has been stable. And actually, Chicago, there's a lot of testing happening in Urbana-Champaign because the University of Illinois,
colleges,
is doing just amazing testing down there. They're testing people weekly. There's been a lot of tests done in that space, and because of that, the positivity rates are actually the lowest in the state in Urbana-Champaign. But after that, Chicago's actually next lowest, where you want to be for positivity, followed by Cook County, and then sort of all the way down. So we're doing better actually here in Chicago in terms of testing access and positivity than elsewhere in the state, except around Champaign. And then finally, response capacity. This gets at the contact tracing and the case investigation. And so this is where the goal that the state had set and that we followed was that we wanted, first and foremost, to have enough staffing to be able to assign cases for investigation within 24 hours of receipt and we had set for kind of the first goal 50% of our cases, the second goal 75%, and the third goal 90%. And we've been just between sort of 75 and 90, closer to 90. You can see we put the data up here. You can look. There have been a couple of weeks we were at the 90. Largely, we've been in the high 80s. Generally good in terms of capacity, and certainly well within green in terms of being able to move ahead. So that is all what we showed yesterday. And if people have additional questions related to that.
Well, I can tell you one question.
Please do.
The minute this press conference was over, I got 2 phone calls.
Yes.
One from a business owner and one from a person who goes to business. The business owner was the Baton Show Lounge. I'm saying your name, Jim Flint. Yes. And he was like, why 40%? Why not 50%?
Yeah.
Because so many of the bars and smaller restaurants could survive better if if it were moved to 50%.
Yeah.
So why not 50%?
Yeah, so the hope is that we're going to get to 50%.
Okay. And I said in 28 days we'll look at it again.
Exactly, that is exactly right. Yeah, and some of this is recognizing that, first of all, it's getting colder. Yeah. And so I know that there are lots of businesses that are struggling around this, but we make our data we make our decisions based on what the data shows us here. And now is the time to sort of take a careful step, see how we do with that. If things continue the way they've been going for the next 28 days, yeah, I'd like to go to 50%. But it's about just being a little bit careful. And folks may have seen that there are some places that have just completely eased those restrictions. Right. And that is frankly, in my opinion, dangerous from a COVID perspective. The last thing that we want to do, we'll do it if we have to, but would be if we were to see a really significant surge, we would pull all of this and even more back if we needed to. My goal is not to have to take big steps backwards. It's to get to a point where we can continue to see our outbreak, in reasonable control, stable or on the decline. We keep seeing data like we've been seeing over this last, month, different from what we were seeing earlier in the summer. We would potentially be in a place to move ahead. And there's nothing magic about sort of these particular percentages. Right. Seattle's at 30%. Like people are at different places. But the idea was, let's do it. Let's let the bars come back at that lower capacity. Let's loosen some of these additional restrictions and see how we go.
But we have to also remember, and this is something that I tell businesses, when you're looking at these states that are opening, like Florida and Texas, they don't have the fear of the flu.
Yeah.
These are warmer climates. We're a colder climate. That's right. And we are looking at our flu epidemic coming and coinciding with this. We have to be very careful with that. So I can understand, although they want to know, realize we are taking smaller steps forward, so we don't have to take any large steps backwards.
That's exactly right. Yeah. That's exactly right. Right. And it is really different. I mean, I love the seasons in Chicago, but boy, would I rather be in charge of COVID in a place that didn't have cold weather.
Hawaii.
Hawaii, exactly. I actually talked to the epidemiologist in Hawaii fairly often, but they have different issues. But
not cold though.
Not cold, but because there's flu, but also even besides flu, there's the fact that people when it's cold, are going to be gathering
Yes.
inside. And we lose that relative, we've talked a lot that, outside does not keep something completely safe,
Right.
but it helps. And we're just not going to have that available, which means as we move into the colder weather, people really need to be doubling down on the masks, on the social distancing, and protecting folks who are vulnerable, and really picking up your hand washing, because that'll help with flu, it'll help with COVID. So.
And buy stock in lotion, because lotion is really doing well right now.
Good advice. I also heard a tip: buy stock in dry ice, because we're.
Oh my God, that's a good idea.
We're planning ahead for potentially ultra cold vaccination distribution. So that was a joke, but
we're not endorsing that.
No, we're not. But I think there are thoughts. Okay, so.
Thank you for that information.
Yeah, definitely. So before we jump into some more questions here, and I do see we're getting some in, I'd like to talk just actually a little bit about specifically the work that the HIV program has been doing around individuals that have HIV that have also been diagnosed with COVID. There can be some real triggers and concerns there. Can you just talk a little bit to that?
Absolutely, just so that the public knows. When we're looking at persons who are infected with HIV, we're talking also about those individuals who we've seen who have also become positive with COVID. And what happens is it triggers trauma. From when they first got infected with or diagnosed with HIV. It triggers trauma around stigma, trauma around medication, health access. So when you couple that with COVID, and then you couple that with isolation and having to be quarantined, and you're talking about individuals who had already just overcome that whole thing of feeling I'm in the world alone, we have a big problem. It sets up a lot of mental health issues. It sets itself up for depression and feelings of isolation and loneliness. So what we've been doing is because unfortunately we don't have as many mental health clinics as we could have, but we've been referring them to our delegate agencies. We have agencies such as Howard Brown Health Center, Brave Space Alliance, which is doing wonderful work with trans, Southside Health Center as well, where they have case management, the Core Center, places where they have case management, but they can also feel comfortable talking about those issues that they're having emotionally. So this has been compounded for not just those with HIV, yes, but also those persons who've had any chronic illness diagnosis and had a feeling of isolation. It sets up so much depression and anxiety. And when you're saying to individuals who are living with someone else, I have COVID now, so I've got to either quarantine myself. How do you do that? So the housing has been a godsend. When we're referring to individuals for housing for isolation and quarantine, as we see them through that. Many agencies, such as the AIDS Foundation, they've been very helpful with case management. The case managers and social workers have really been working in overtime. I know we have a lot of frontline workers, but the case managers in some of these community-based organizations have also been putting in a lot of work and a lot of overtime. Because they're dealing with individuals who've gotten used to going to see their primary care physicians in person, and now you've got to do it virtually or do it over the phone. I know my doctor, when I went for my checkup, I had to do it over the phone. So I can't imagine what that's like for someone who is HIV impacted as well as COVID impacted, and you've got these underlying health conditions. Your immune system is already impacted, and you've just built it up, and here comes COVID, bam. So it's causing a lot of anxiety, but we have been doing due diligence in referring those individuals to great agencies that can do the work of helping them to navigate through those emotional distress issues.
Thanks. I think it's helpful because I think so often, we've even had people asking questions about how do we make sure people are getting their medications related to HIV. I mean, all of this is important, but I think that sort of mental health and support piece is not always what comes to mind first. It doesn't come to mind first
unless you're dealing with it. If it didn't come to mind for me until I got the phone calls from the community members and from friends who were like, look, I'm home, I don't know what to do, I'm about to go crazy. And then when you factor in substance abuse, those who have dealt with substance abuse and have been doing great, been in sobriety, it can be a daunting situation. So we've got to look at that as well. And these are situations as the health department we're going to see coming up for years to come. So I'm hoping there's some CDC funding coming from the government for mental health issues and to deal with that.
So the good news is, Yes, we definitely hope there is CDC funding and government funding coming for a lot of these issues. But one of the good news related to this is actually that we had made, Mayor Lightfoot had really made a decision to prioritize mental health even prior to COVID. And so we've been able to actually make some really, I think, important new investments. And, to the point of, are there enough clinics? Is there enough access? There is still availability at all of CDPH clinics, and that's a place people can get care for free. But we'll also actually just very shortly be announcing a lot of other community-based clinics that we're going to be able to get some additional funding to.
Well, she had in her first budget, she had $50 million set aside to help and assist in mental health issues as well.
So
that was great.
Yeah, more than a doubling and perhaps even a tripling of what we've had available for mental health, and a lot of work for also getting not just the clinic, but making sure that we're getting mental health resources out to people who need them. People who may have, as you say, substance use issues or other kind of serious mental illness where they're having trouble perhaps keeping appointments. Like, how do we really make sure services are getting to people? So.
And another thing was brought to my attention, I didn't even realize it, those individuals who've had eating disorders.
Yeah.
You're sitting at home now in COVID, and one lady, she's like, I'm back to eating again.
Yeah.
And 50% of, you're a doctor, 50% of Americans are noted supposedly to be obese. Mm-hmm. How is that being affected now with COVID? And you're sitting home, all you can do is eat.
That's
We've got a lot of situations that are going to be coming up that's going to keep us employed and keep us busy for a long time.
I know. And this is where, we've talked about trying to keep some of those healthier habits. It's so hard to do, people joke a lot about
an apple or a Twinkie.
Yeah.
Twinkies going
and people joke about the
COVID weight.
The COVID-19 or the 15 quarantine. But it is true that we are not a society that can sort of stand at a societal level to gain extra weight. Yeah. And we've seen that in COVID, and people's exercise regimens have been disrupted, mine among them. And so, trying to sort of, particularly as we're moving into fall and winter, I think, that tends to be a time where people are home more, sometimes less active, really trying to keep in mind, how am I going to make sure I'm getting some exercise in, try to kind of get some of that healthier eating going again.
One thing, Mayor Lightfoot had some great suggestions about walking in your neighborhood.
Yeah.
Putting that mask on. Taking a walk with your friend, keeping that distancing, but making sure you're walking through the neighborhood just to see people again.
Yeah.
It's a good idea, especially in the fall. Fall is great. I can walk in the fall. I'm not walking in the summer. Yeah,
walking is great exercise. It's good for your mental health. It's good for your physical health. Absolutely.
So Dr. Arwady says walk.
I do. All right, so we've got some other questions coming in. Let's see. Brittany Steiger on Facebook is asking, as things start to open up more broadly, what advice do you have for moderate to high risk persons on whether or not they should resume some activities? So good question. So I would continue to refer you to that Think Twice algorithm that we've shared. We can post a link in the sort of in the chat box here so you can find it. But this is this idea that I think first about myself and whether I am over 60 or have these underlying conditions, but also about anybody who I'm in close contact with. And so to this point of, if you've got someone who's moderate or high risk, you want to be thinking about activities. And then we ask you to sort of think about 4 things related to the activity. Number 1, can you always wear a mask, and can everybody else? Number 2, can you avoid crowds where you don't know who you're exposed to? Right. Number 3, can you, is it out of doors, which is lower risk than indoors? We're about to lose that one.
It's not risk-free though. It's lower risk.
It's not risk-free. Right. It's lower risk, exactly. So anyway, you put these in and you see, how does my
personal situation,
my situation match up against this particular activity? And and then the last one is, can I always keep 6 feet of distance? And so if you're in which that's right. Thank you. We forgot to check our social distancing, but we are. And so if you're in a setting, even if it's indoors, if you can tick those other 3, that's going to be a relatively safe setting. But if you're in that higher risk and you're not in a setting where everybody can wear a mask and people can't keep their 6 foot distance, or there's going to be crowds, the advice remains the same. As much as possible, avoid those kinds of activities. And especially, everybody's going to have some different decisions about priorities. And that's very natural. So what I try to do when I'm thinking about my own risk is not to sort of pile on too much risk unnecessarily. So I might decide, I really need to get a haircut, which I do actually right now. And I know that that's not a setting where we can maintain a 6-foot distance. Obviously, I keep the mask on, etc., but there's a little bit of risk in there. So if I'm getting a haircut, maybe that's not the same day that I'm going to dinner and getting together with friends, adding a lot of unnecessary risk together. It's not that you can't do these things, but I want you keeping in mind who, not just me, but who in my bubble is at risk, and then how do I limit that risk appropriately, and really be careful about protecting people who are more vulnerable. If I was going to be in close contact with somebody who's older, who has underlying conditions, I would be especially careful in the couple of weeks leading up to that. So it's some of that kind of decision making. Everybody's going to be making their own calculus of risk there, but the ask is really to keep conscious about it. You want to add anything to that?
Well, only, but I know that when I'm talking to individuals, I say the same thing. I've got a friend who's traveling, and he wanted to also go to a funeral. I said, well, you're going to be traveling to see your grandmother. You don't want to go to the funeral and then go see her 3 days later. Make a decision to maybe send a note to the bereaving family, the grieving family, so that you are continuing to make sure that you're being safe, so that when you go see your grandmother, you're at a lesser risk for her. Those are the kinds of decisions. You're right. We have to start thinking in a different way. What do I want to do with my life? How can I make sure I'm not compounding the risk more so than I should?
Right. Absolutely.
I've had to think about that.
Yeah. All right. Lori Holmbaum on Facebook is asking, what are your thoughts on the new CDC update yesterday that rapid tests are ready to deploy? So, yes. So this is, there was an announcement. It's actually been an announcement over a few weeks, but that the U.S. government purchased a lot of what are called rapid antigen tests, which are these card-based tests that you don't need to send to a laboratory. So they are exciting in that they are a true point-of-care test, meaning that you can get a test and get a result sort of on the spot. So a good advancement. Note that they're antigen tests, and for those people who have been following along, that means it's not sort of the standard PCR diagnostic. It's not an antibody, which is the blood test. It is a test meant to be diagnostic, but it's not quite as sensitive and specific as the PCR tests are. They're good tests, but officially they're designated for people who are symptomatic, having symptoms from COVID. Now, the government has put some additional language around there and has said that particularly in settings where perhaps you're using these repeatedly or it's hard to get access to other tests, doing a lot of testing with a test that is not quite as accurate, the benefits outweigh the risk there. And so the first distributions of these are going to long-term care facilities. They're also going to some of the tribal communities here in the U.S. that have had particular accessing testing. I know they were going to some of the historically black colleges and universities. They were going to some other settings sort of depended on decisions and some, but they go to the state. And so the state then gets to make some additional decisions around what that distribution will look like. Certainly, they have opportunity, I think, to be very helpful. I'm excited. We were not able to purchase these tests because the federal government
took it over, right? Good.
Yeah,
that's good. That's a good thing.
Exactly. Make sure that it's distributed appropriately based on population, the whole thing. So we're just starting to see. One of my, I think it's great. One of my concerns, though, is that when it's a point of care test, think about like if you do a pregnancy test or something, there is nothing that attaches that test result to a laboratory, which means there is nothing that means that test result is automatically getting reported to the health department. And so we are a little bit concerned that as these point of care tests come in, although it remains a legal requirement to report these, that we are probably going to see less reporting because people are very used to having the lab do the automatic reporting for them. So keep your eyes on this space. Certainly, any additional access to testing I'm excited about. I love seeing advances in this, but we don't have control at this point over where they go. And first, I think we'll see them in long-term care settings. Okay. Let's see.
Vaccinations.
I
know our time is winding, so vaccinations.
Yeah.
Well, I wanted us to make sure that you, because you have a great way of explaining things, explain how this new vaccine is going to roll out and why it's important for us to trust at this point that the government has not hijacked the CDC or hijacked the FDA.
Yeah, absolutely. And I think, there's a history, as we've talked about,
yes.
right? How we've treated marginalized communities in the past. What does this look like? So there's, lots of conversation there. But at the end of the day,
yes,
we really want to make sure that the process by which any vaccine is approved follows the same scientifically based process that we've followed for any of our other approved vaccines, our childhood vaccines, et cetera. And that means allowing the science to progress like it needs to. We're in these big trials at this point now. Those need to continue until we have enough data. You can't just magically choose a date like November 3rd and say the testing will be done by this date. It's just not possible. But the good thing is that where there's been some work to speed this process up, it's not been in anything to do with the actual science of doing these tests. It's been more that there's been work to start manufacturing these vaccines that show a lot of promise even before the testing is done. Now, if the testing shows that this vaccine is not safe or is not effective, you throw out all that vaccine. But it's worth the investment because obviously getting to a vaccine is a major piece of this.
So there hasn't been any shortcutting to the research.
There's not been shortcutting to the research. That's right. There's not been shortcutting to the research. And we will have, and once these trials are completed, and certainly once there's a decision that a vaccine has been approved, let me tell you, I will be looking at that data with great interest, and we're going to get science and medical folks from around Chicago and probably around the state to look at this, to review it, to make sure that we're collectively saying, yes, like we trust that this science has been done well and that this vaccine makes sense not in a political way, but in a scientific way. So
thank you for that. That was very important.
Yeah, and there's been a lot of questions around there.
No, I was going to say, so many people are like, I'll wait till the second or the third one. And, I think that there's been even a larger number of individuals from different ethnicities and cultures actually part of the trials, which is a good thing. Yeah,
definitely. We want this, right. We want these trials to be representative of the U.S. And of communities that have been, disproportionately impacted. So, for sure. All right, we are unfortunately wrapping up on time. That went really fast. I think we're going to have you back again. is what I'm feeling like.
I don't have any questions. They were all for you still.
No.
It's your fan base.
No, but I think lots to talk about with this. Anything else that you want to bring up sort of as we're wrapping up here?
I would love to, because I'm the LGBT Health and Outreach Liaison, I want to commend our LGBT agencies, which have stepped up to the plate to not just do their programming, but to also infuse within their programming. They're doing food banks, such as Puerto Rican Cultural Center, Brace-Based Alliance, congratulations. Brace-Based Alliance purchased their floor today. They've got a permanent residence in Hyde Park. That just happened today.
Good.
And they're doing a wonderful service for the trans individuals in the city of Chicago of all races and ethnicities. LaSaya Wade and Stephanie are doing an excellent job there. I just wanted to commend the community for coming together in Chicago, for coming together. We're doing a great job. We're doing really great. And I think that what we can do is probably check on those individuals that who are HIV positive, who may be going through some isolation, and check on those individuals who have other chronic illnesses who may not be able to get to their doctors and see them in person. Sometimes those are the only visits they can get.
Yeah.
That's the good news.
Yeah, I love it. No, that's good.
And if a contact tracer calls you, verify the information to make sure it's not a scam, but we will have contact tracers calling you. They're doing a great job. We've been doing a great job, and we expect our CBOs, our community-based organizations, to continue that great work.
Yeah, and they'll be calling from 312-74-COVID. That's the new number with our new technology
platform. Is that the new number?
Platform. Yep. That'll all be coming from. So that's great. Thank you again, Antonio King from the Chicago Department of Public Health. I learn something every time I talk to you.
Thank you for having me.
I think I will just end with two very quick things. One is a thank you to Ford Motors that donated 1 million masks.
You got a car?
I did not get a car. If you saw the car I drove, you would know that No. Yeah, so, we were able to do another really good round of masks to shelters, to the Cook County Jail, to city workforce, to people coming into city buildings, to aldermen. The city has continued to purchase a lot of masks throughout this, but we really appreciate when we get these large donations in. So that was great. And then just one more thing, if you look on chicago.gov/coronavirus, if you're between the ages of 18 to 29 or you know somebody who is, please fill out. There's an anonymous survey that we're using just to help us design interventions, get some thoughts about what people are doing and thinking related to COVID. So you can find it right on the website. And I think with that, man, this went fast today.
It did go fast.
I think partly because we went over all that data. So
well, that was a good thing.
It was, but I think we're going to have you back again. In any case, I will be back on Thursday. We'll make sure we get through a lot of your questions on Thursday. And thank you so much, and be safe, Chicago.
Wakanda forever.